Now it's time for tip-episodes with quick tips you should know. Techniques you can implement into your workflow right here on A Tale, oh yeah, A Tale of Two Hygienists.
Listeners, welcome to this week's tip-episode. This is an interesting one. I'm joined today, Tom, I'm sure you know this already, fan favorite, Tom Viola. Welcome back to the show, sir.
Thank you, Andrew, my friends. Always a pleasure being with you. Always a pleasure being on anything to do with A Tale of Two Hygienists, including these tip-episodes. I love them. They're great.
Oh, man, they're so good. It's nice. We have a good question for you today that is, it's a bite-size format, these tip-episodes. This is a kind of a complex answer, probably. It's a complex topic. So I understand if we can't get to all of it, everyone make sure you guys go check out, Tom doing some other stuff, his lectures and things like that, so you can get a better update. But the listener, this is Dr. Pier, and she wrote in, longtime listener with a question / review request. Blood thinners have changed a lot since I graduated from dental school. I recently had a patient that had significant bleeding 24 hours after SRP. She had noted on her medical history that she takes blood thinner, but didn't indicate what kind. And then she mentioned what kind specifically. Had I known it was this kind specifically, and it stops all clotting, I would have changed our protocol. But that leads me to wanting Dr. Tom Viola. Could he please, I love when people request you specifically, could he please do an update on blood thinners? I usually run into Eliquis and Xarelto, but would love an update, etc. on this. So Tom, let me put this back to you. This is, it sounds like from the email very specifically, we'll start with SRP protocol. Is there anything different that we need to know? Are some blood thinners more dangerous than others that we need to have on our minds? How would you like to answer this email?
Yeah, let's go over the two different kinds of medications that a dentist or a hygienist would run into or encounter when it comes to quote unquote blood thinners. So first off, none of the drugs we're going to talk about actually thin the blood, right? There were drugs like that in the past, Bletal, Trental, but those drugs actually reduce the viscosity of blood. So you could say they thin the blood. But here we're going to be talking specifically about two different kinds of drugs, antiplatelet drugs and anticoagulants. And there's a difference, obviously. All clots start with platelets clumping together. So antiplatelet drugs, and some people would be more familiar with the drug Plavix, but also Brilinta is one of those as well. Those drugs make your platelets less sticky. So they're not actually anti-clotting drugs. They're not actually anticoagulants. They are antiplatelet agents, which means that they make your platelets less sticky. And therefore, in the big scheme of things, since in dentistry, we're always trying to really assess risk and qualify risk, I would say that patients on these medications may not bleed as much as somebody who's on a true anticoagulant, but say never, right? Because they certainly could bleed, considering that these drugs specifically target platelets. A drug that most people would be more associated with or more familiar with would be aspirin, 81 milligrams, has the same effect, that same anti-platelet effect. So we have those drugs, right? Plavix and Brilinta being the two most popular. But then we have anticoagulants, which are anti-clotting factor drugs. The one that most people would be familiar with would be Coumadin or warfarin, which was, a vitamin K clotting factor antagonist. So essentially, Coumadin, warfarin, blocked all of your vitamin K dependent clotting factors. That means two things. One, you're not going to clot, and the risk of bleeding, severe bleeding, is, I would say, significantly greater than, let's say, with an antiplatelet agent, but not all the time. Depends on the patient's propensity for bleeding. But it also meant that if you were on Coumadin, that risk was real enough that you had to go for a blood test every 2 weeks to make sure you weren't too anticoagulated or not anticoagulated enough. We had to draw your INR every 2 weeks to find out where you were. Also, because it was highly dependent on vitamin K clotting factors, you could not eat vitamin K. So you couldn't, eat spinach and kale and broccoli, all the green leafies, because they had vitamin K in them, and that would increase the risk of throwing your Coumadin ratio with your clotting factors out of whack, making it more difficult for the Coumadin to work. It would work actually against the Coumadin. But at the same time, if you needed to stop Coumadin, if you needed to reverse its effect, let's say you were experiencing an exaggerated effect of Coumadin, you could always reverse its effects with vitamin K. So it was a good balance. You had vitamin K there at the rescue, but you had to avoid vitamin K in your diet and sort of try to keep the peace. And I would say Coumadin's major downfall, if anything, was it was much like a freight train. It was hard to get started and hard to stop. And so it wasn't as nimble as we'd like. Well, along come the newer anticoagulants. So Plavix is an antiplatelet agent, and Pradaxa, a lot of people get them confused. Pradaxa is an anticoagulant, but it differed from Coumadin in that it only blocked one clotting factor, and that was thrombin, factor 2, factor 2A. So as a result, because it only blocked one clotting factor, it did not involve a blood test every 2 weeks. The INR was essentially worthless because Pradaxa only blocked one clotting factor. After that came the other three drugs, Xarelto, which a lot of people are familiar with, Eliquis, which is even more popular, and my new favorite drug of all time, Cerveza, because it sounds like cerveza.
Cerveza.
They could use a little more cerveza in their lives. Yes, so those three drugs are relatively new. They are factor 10A inhibitors. But again, since they only block one clotting factor, they don't require the INR. They don't require a blood test. Matter of fact, the INR would be worthless in that case. On the one hand, you're saying, that's wonderful. I don't have to take a blood test every 2 weeks. Amazing. But on the other hand, you're saying, wait a minute, there's no blood test. So how do I know it's safe to work on this patient? And the answer is you don't. Now, Dr. Pier's question was regarding Brilinta. Effient is another one of those antiplatelet agents. They're very similar. But Plavix will always be the big kid on the block. And then again, you've got Coumadin, you've got Pradaxa, and then you've got Xarelto, Eliquis, and Cerveza as anticoagulant agents. So yes, a lot has changed since the good doctor, I'm assuming, went to school within the last 10 years or so. A lot's changed. But bottom line, what does it mean to the dentist or the dental hygienist? It means that if your patient's on an antiplatelet agent, they are more than likely less likely to bleed significantly. But again, that depends on the patient's propensity for bleeding. Some people bleed more than others. If a patient's on a true anticoagulant, like the ones we mentioned, well, they're more likely to bleed. And so if you're talking about SRP and you're talking about, what kind of protocols, I would anticipate the worst and hope for the best, right? Because it's possible that the bleeding could be significant. But let me put it to you in a different way. You, after hearing me say that, you might say, well, heck with that, Viola. If they're going to bleed so much, I'll just tell them to stop taking it. Again, that would be something that's the doctor's call, all right? And not only the dentist doctor, but also the medical doctor. I'd certainly get the consult for that. But bottom line is, I've always followed one principle when it comes to anticoagulation or antiplatelet drug therapy. And that is, I can always treat bleeding. Somehow, I can always stop bleeding, okay? Within reason. But I can't stop a clot. Once a clot forms, it's a bullet waiting to find a target. So I would say I'd always err on the side of conservative and try to make the patient continue to take the medication and work around it as best I can.
I love that. I love it so much. I think that's really important that not only do we have emergency, preparedness protocols and stuff in place, but also working with our medical providers to make sure that we're on the same page. You should have, I think where Dr. Pier is, from what I understand, it's kind of a smaller community. And I think that she probably has a really good working relationship with the medical doctors there, which is great. Tom, fantastic. Like always, if someone want to reach out to you, ask you some follow-up questions, or if they want some clarifications about the things you said today, how can they reach you?
Yeah, please. And if one more thing, Andrew, just make sure that, if you're in practice and you're going to be dealing with bleeding, there are agents you can use, tranexamic acid, aminocaproic acid. There are epinephrine. There are things we can use for hemostasis. And if people have more questions about that or anything we talked about today, they can reach out to me anytime at my website, tomviola.com. My email is tom@tomviola.com because I'm a simple-minded man and I named everything after myself. And since my daughter has my social media, well, that's more complex because she's smarter than I am. And that's Pharmacology Declassified on all of the major social media chats.
I love that. We'll make sure to put that in the show notes, everyone. Thank you so much again for being here. Have a great weekend, everybody.
Thanks, everybody.
A tale of two hygienists.